Hello.
Good morning.
Good morning. How are you?
Bring yourself.
I'm well. I'm well. In an undisclosed location. No, I'm kidding. In the back cave. No, I am in Montgomery, Alabama. We had a death in the family, and so I came down for the funeral. I
Oh,
have a funeral today, and then back home in Cincinnati, I have a funeral on Monday.
oh Lord, I'm
I
sorry to hear.
know, I know. It's on all sides of the family, so it's like you gotta show your face, gotta do what you gotta do.
Right.
And my daughter went to school. This is her dad's family, and she went to school in she was at Alabama State, and so they took care of my girl while she was here, and so they've always been sweet and kind to me, um, and has always regarded me still as family. So
Good.
definitely come down and support her daughter, and the rest of the family. So yeah, yeah. And she was 90. She was 90 years old, and still mowing grass, living by herself, mind very sharp, just doing all of the things. So yeah.
Oh,
Yeah,
wow. Okay.
yeah. Yeah. How are you? How's your week?
It was busy.
Yeah. Yeah. With this added, I was like, okay, how am I gonna get all this stuff done? What am I supposed to do? It was the struggle bus was real, real. Okay, well, let's get started because I do have a tight hour because we got to go to the funeral. Welcome to our Saturday morning tea where we discuss health information, news, education, certification tips, and entrepreneurship. The revenue cycle at large, just all of the things, funerals, uh, family, some fun, but all of the things. As you come in, don't forget to hit the thumbs up or like button. I am Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. Woo, child. Can I say that again? Where coding education is key. Oh my God. Woo, because folks is out here in these streets living reckless. But anyway, PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. But let me ask you, do you know what it takes to be a certified marketable medical coder? Do you really? Are you sure? Well, before I introduce my co host, let me share with you information on a free email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
All right. So, if you are interested in getting more information about the 5 steps to become a certified marketable keyword medical coder, check out the description link if you're joining us via YouTube, Facebook, and LinkedIn. I promise you it's down in there. So joining me today is my illustrious co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I've been a nurse for a very long time. I transitioned into HIM in 2014 during a pandemic in 2020. I created a company called The Coding Nurse where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
And how is all of that going?
It's going well. I'm just finishing up a class and now like they're doing their final, so I'm waiting for them to they have to submit it by tomorrow. So I'm
Uh-oh.
just waiting. Yeah.
Uh-oh. And they're good. You think you got
Yeah.
okay. Okay, love it. It's always great when you have students that you see excel and go from where they started to where they are. It's always at least it brings me joy to see that
Yep.
growth in people and see the confidence that it builds for them when they're going out here and you're sending them off into the world and knowing that you're sending them off well educated, well prepared for what's to come. So yeah, love it, love it, love it. Okay, so before we jump in, let me remind you that um, you are free to join in on and add to the conversation. So don't be shy. This is a conversation. Again, we bring up the topics, but we also want to know and hear your thoughts related to the information that we share. So your opinions and they matter here and they are welcomed here. So feel free to join us. And most of you all know what to do. You get into that chat and you be chatty. The chat be chatting. Now, our on this scene correspondent won't be with us today, the crafty coder. She's actually at an orthopedic conference in Nashville. I was like, oh, I followed you. I came through Nashville to get here. So, so she said, but she would definitely join the replay. And I'm sure she'll be putting her comments in the replay. All right, all right. And then if you have a question specific for us, please just put a Q first so that we know it is a question for us and we won't miss it. So for those of you who are just joining us today or listening to the replay, we are talking buckle up, Buttercup. When I saw that, I just chuckled. Buckle up, Buttercup, and get ready for the regulatory rodeo. But before I get to that, let's get to our church announcements. Oh, and I'll have some surprise for you next.
Oh Lord.
All right, all right. Our church announcements. Wait a minute. The spirit has moved. The spirit has moved and hands are raised. Absolutely love it. Okay, so our church announcements for today. Let me show my screen here. Okay, which one of these are going to show? Let me see. Okay. I want to first of all congratulate Miss Tanya Bates from Ohio on being elected to the AHIMA Board of Directors. My girl is out here doing big things. We got the announcement last week that, yes, she was elected to AHIMA. So she's leaving us at OHIMA, but going on to bigger and better things. And I told her, girl, you paving the way. You let me know. I'm gonna follow your footsteps.
Mm-hmm.
Let me know what it looks like over there. So I'm excited and congratulations to her. The other thing is, and this kind of falls into the regulatory piece, if you will. Wait, let me stop sharing. Falls into the regulatory piece. Did you hear about the overturning of one of the cases related to malnutrition? And back in, I think it's 2017, the Vivint, wait, where's the name of the hospital system? Because they've changed their name or since changed their name to ECU, but they were Vidant. I'm sorry, Vidant Health. The administrative law judge, or ALJ, overturned their ruling from they appealed. They held strong and appealed And look how long ago that was, from 2017. And they won. There were 20 or 77 cases that were in question. And kudos to the administrative law judge. Let me just say that, because the judge pretty much judged, did what they were supposed to do, and reviewed all 77 cases one by one. One of the big issues related to this, one, we've talked about malnutrition a lot, and it's something that comes up a lot, and there's several issues related to coding malnutrition. I think the issue, because and malnutrition has been one of the targeted diagnoses from the OIG in several targeted probe and educate reviews in supplemental medical review contractors for Medicare Advantage and commercial payers. It's a big thing. Even OIG Medicaid reviews, they're looking at malnutrition a lot. But the thing that I saw that just jumped out at me was, at the time of the review, and I'm not 100% certain if that's the case now. Prayerfully, it's not, but if it is, we still got a problem. But at the time of the review, and the issue for this case wasn't that there wasn't any documentation, there wasn't criteria on documentation for malnutrition. So the guidance was silent as it pertains to diagnosis, and there was no official CMS policy or rule for diagnosing and treating malnutrition. There was also no applicable local or national coverage determinations those are part of the landscape that determine and guide you on the appropriate coding based on all of the things that could potentially happen with a patient. If they did this, then do that. If they do this, do that. They got to have all of these different pieces in play before progressing to the next step. None of that was in effect. There was also no regulation or statutory provisions, and there was no American Medical Hospital Association standard. However, the providers used what they call, quote, a classic approach, and there was also something called Aspen. And I don't see where Aspen is. Oh, Aspen is the American Society for Parental and Enteral Nutrition. They use the Aspen criteria, and they mentioned to them several times that the Aspen criteria was used. And unfortunately, they shot that down. But my spirit says, well, wait a minute. If you don't have any official guidance to the fact, how can you just tell them what they did was incorrect? And they sent and supported their documentation with the criteria that they had. In the article, there was an article by Nina Youngstrom in the report on Medicare compliance that talks about the ALJ overturning all malnutrition diagnosis in a hospital appeal because CMS has no official policy. So again, this is kind of putting the onus on them to get that together, because you can't come out here guns blazing and your house ain't in order. I don't understand that. But the other thing was that I wanted to say, it says this was quoted by the ALJ. It's unclear what criteria the CMS contractors use to analyze each case in this appeal, as the CMS contractors reference, quote, criteria but none of them cite to a single source. So again, you really don't have any black and white specific things that you're actually applying to these cases. And the ALJ also said applying the guidelines, said the medical records support medical coverage and payment of the inpatient hospital claims, including the principal and or secondary diagnosis codes. And then says this decision refers to Pitt County Memorial Hospital, which was Vidant's previous name. So in this article, like the ALJ, they broke down a few of the cases, like what was happening with the patient, the muscular depletion, the wasting, all of the things. And these are part of clinical categories that Aspen uses to diagnose severe malnutrition. And I think that was part of the issue, that they were stating that these cases did not warrant the diagnosis of severe malnutrition. Yes, malnutrition, but not severe. And so I think that's where they were splitting the hairs. But again, ultimately, they won, and rightfully so. Again, because if there is no clear guidance on that, this is going to cause a lot of other questions. And for me as a reviewer, the first thing I would ask is, well, what's the guidance? Because that's your roadmap. That's what you use to kind of decide or determine how you approach this audit. So I don't know. There may be other opportunities here. As I'm speaking, it's my mind just clicked on. But but what are your thoughts on that? I'll let you.
I definitely agree that, I mean, first of all, malnutrition has always been one of those, everybody knows that it's on OIG's radar, but everything comes down to guidance and what is the standard, because where I work, they don't use the Aspen criteria. They use something else. And that's why there needs to be some consistency across the board, because you can't, I'm just really, I don't know how you can effectively monitor something that you don't have any standardization and process. Like, how do you do that?
You're right. I mean, because again, when you build the targeted probe and educate, what are you educating to? I mean, right. You should have the documentation or the guidance to say, okay, this is where we're teaching you. This is where we're providing you the information on what it is that you need to do. So that way they have a roadmap to say, okay, well, we've met this, we're good. Next. But it's kind of ambiguous out there. And so then it leaves the provider community in a fray, and rightfully so. So again, kudos to that ALJ who, did the work and broke it down and was like, well, wait a minute, sir and ma'am. How you gonna punish them? Extrapolate, because it was millions of dollars that were at stake here. Extrapolate and then not have the information and the stuff in the road to kind of put their feet to the fire. That to me, this wasn't fair. Right. And sometimes if your stuff ain't right, you gotta lick them wounds and be like, my bad, I'm sorry. Right. But I think they still came hard with, but we followed. They said something. There were some comments they said, I think, the OIG spokesperson said, we did a coding and medical review and the medical records didn't justify the malnutrition codes. The coding rules were applied in this audit. Yeah, but we are also talking guidance too. And those providers don't code. We've said over and over again that they shouldn't be coding. Yeah. So that was part of the church announcement. I didn't know if you wanted to talk about the gentleman who's now heading the nurse organization.
Nurse practitioners. Mm-hmm.
Yes. In your church announcement.
I I'm just well, I got tickled when I got to the article to the part of the article where he talked about scope creep. I tell you, I find that phrase just hilarious. That's number two. The compassion and sacrifice lives
That's
rent
number
free.
one. Yes.
But I, I'm just well. We all I know what it all comes down to. It all comes down to control, because we know that yeah, because we know that there is a horrible shortage of providers. We know that. And why would you fight so passionately to stop people from becoming providers? Because you're denying access, you're denying care to huge swaths of people that you either can or don't care to really address.
Yep.
So why not let somebody else do it? I mean, I don't see it as a either or. I see it as a win-win, because if your ultimate goal is to take care of people, then why would you stop it? I mean, I know why, but how can they justify it?
Right. Right. Yeah. Yeah. I don't get it. You would think you would embrace them. At a minimum, they're giving you a break. To your point, if there are areas or pockets that you be like, you know what, I'm not fooling with them folks over there or that
Mhm.
area or whatever, for whatever reason.
Right.
Here is now a group of people who will. And why not let them? Why not let them? And encourage them and be supportive
Exactly.
of them. I'm like that. I'm with you. It feels strange. It feels some kind of way. Let them do what they do. Okay. So getting to the meat and potatoes of our topic for today. We talked about um last week what was going on with the civil rights um investigation for maternal health. Well, United Health is being sued by um, the U.S. Department of Labor over thousands of claim denials. And they are alleging that United Health Group denied thousands of patients payment for emergency room services and urinary drug screenings. And I thought this was real interesting that it's coming through the Department of Labor. Um, they deny all of the urinary drug screenings from August 2015 and August through August 2018, when it should have determined whether a claim was medically necessary, which violated the Employee Retirement Income Security Act, or ERISA. And that's why the Department of Labor has gotten involved. Of course, United Health Group didn't have anything to say about it. They didn't have any comments at the time. And then they said they changed it. The lawsuit says that UMR changed its urinary drug screening process in August 2018 because 98% of those claims were overturned upon appeal. It says medical plans through UMR are required to directly define a prudent layperson standard through the ACA. A prudent layperson standard requires insurance companies to provide coverage for emergency care based on symptoms. After denying a patient ER claim, UMR sends an explanation of benefits that has, quote, very limited information, the Department of Labor claims. Denied claims do not point to specific plan provisions or rules. The prudent layperson standard state whether there was a lack of proper documentation or provide a description of additional information to further explain the decision. UMR allegedly does not inform claimants of the informal appeal process either. So that says only limited information was given to patients who had urinary drug screening payments denied as well, as UMR did not reference plan provisions or provide a description or explanation of the failed claim. The claimant was filed in the U.S. District Court for the Western District of Wisconsin, and says UMR is believed to handle at least 2,136 ERISA-covered health welfare benefit plans in this location. So more to come on that. Buckle up, Buttercup.
Yeah.
They're coming. And this was an article by Noah Tong in Fierce Healthcare. The other article, did you have anything you wanted to mention on that?
Of all the things to deny, I'm just
like, don't do that. Like,
exactly.
I'm sure there are bigger fish to fry out there. So why play? Like you said,
and
why?
We all know that most people, we know that the majority, every urine drug screen I've ever taken has been for employment. I just don't understand.
Right. And so now you got somebody else, it's one thing to have HHS all in the fray. Now you got another government organization who, you may not even be up on those particular rules. You may not know what those standards are. And now you got somebody else who done said, well, wait a minute, who then may think, okay, well, if they doing it, then they might be doing it and they might be doing it and so on. And now you got another government organization. Y'all don't want this government regulation, but y'all giving it to them. Giving it to them. Easily, just handing it over to them.
Because it said urine drug screens and other emergency services. I'm like, I would love to know exactly how many urine drug screens, how much money, how much of that 91 million was strictly urine.
Right.
That's what I would love to know, just out of curiosity.
Right. So interesting. Good morning, everybody. I'm sorry. Good morning, Renita. And good morning, Makeup by Shelby. Good morning. Good morning. Thank you for joining. All right, let's see. The next thing was my friend over there at Becker's Hospital Review. When I tell you, I get excited when that email hits my box, because I know it's full of stuff from the hospitals that are closing to the CEOs and CFOs that are jumping ship or relocating and moving to this regulatory rodeo. And when they put this article together, they summed it up pretty much. So Andrew Cass wrote an article that kind of is taking a stroll down recent memory lane. This is the Justice Department charging 78 people in a $2.5 billion scheme to a woman being sentenced to prison for leading a $24 million scheme. There are 11 healthcare billing fraud cases that have been reported, at least by Becker's, since June 20th. That's a lot.
Of this year.
Yes. A lot. Like when we say they coming. The first one, you got a group of California healthcare providers, including 2 health systems and a health plan, that agreed to pay $68 million to settle allegations that they submitted false claims to Medi-Cal related to Medicaid adult expansion under the Patient Protection of Affordable Care Act. The justice system charged 78 individuals, including 24 physicians, for their alleged participation in a sweeping $2.5 billion telehealth, pharmaceutical, and opioid distribution fraud scheme. In Massachusetts, a pharmacy that has bought some of the nation's largest quantities of opioids agreed to pay $10 million to settle a lawsuit accusing the company of improperly dispensing drugs and submitting false claims. a federal jury found a California woman guilty of leading a scheme that billed Medicare more than $24 million in fraudulent claims for medically unnecessary durable medical equipment and repairs. A father and son pleaded guilty to a $21.7 million scheme to defraud Medicare through fraudulent medical device prescriptions. The owner of 2 Connecticut mental health clinics was sentenced to 30 months in prison for submitting over $1 million in false claims to Medicaid. A Wisconsin prenatal care coordinator was indicted for an alleged $2.3 million Medicaid fraud scheme. A Missouri home health owner. You see all these variances out here, they coming for everybody. Everybody was sentenced to 5 years in prison for a pair of fraud schemes, including defrauding the state's Medicaid program out of $1.2 million. A Georgia physician could face more than $27 million in fines after a jury found he had violated the False Claims Act by submitting false diagnoses to Medicare. A chain of Georgia urgent care clinics will pay $1.6 million to settle allegations they overcharged Medicare by upcoding COVID-19 evaluation and management claims. And then number 11, an Illinois physician was sentenced to 6 months in prison and fined $1 million for billing fraudulent claims to Medicare and Blue Cross and Blue Shield of Illinois. Yeah, the fraud is out here and they catching you. And then there was something else that came on my radar. I think it was in LinkedIn. But Mr. Jesse, did you want to comment?
I just wanted to say this just goes to show you, and we say it all the time, it is not how much you're able to bill, is how much are you able to keep.
That's say it. What'd you do?
Because this is all of this, and this is only the tip of the iceberg, because now that COVID is over and the government has officially ended the pandemic, they are scouring. They are coming after their money.
Coming.
This is just going to be an assembly line, because we know, I mean, fraud was going on pre-COVID. So when they loosened up the reins and wasn't really checking, they should have known that was not going to last. I mean, we're going to be hearing about these fraud cases for years to come, because now that they're scrutinizing everything. And now with the help of AI, you know, they can go in, and not just AI, but data analysis. They can go in and see trends. They can go in and see all kinds of things, just so their focus can be a lot more targeted.
Yep. AI helps on both sides. Speaking of, well, I'll come back to that because I listened as I was driving down here to the ICD-11 work group, where we talked about this before, where they're considering or trying to get comments on whether or not the CM portion is relevant and should be made available. And this one provider, I believe he was a provider, and I don't have the quote in front of me because I was writing it down while I was driving and it's still sitting in the car. But he said something related to AI about basically, in a nutshell, providers want their documentation coded using AI technology that is accurate, something he said, but it was the using AI technology piece that kind of stopped me in my tracks, because it was like, you don't want coders to do this? You think the AI should take a stab in doing it? And there was a lot of discussion around that. And there were a lot of coding professionals in the room. that had some comments on that too. So I'll do a better job of summarizing that, and I think we'll talk about that more next week. But when you said AI, that just hit my spirit a little bit. But anyway, this other thing is the OIG released another Medicare Advantage compliance audit report for the Presbyterian Health Plan. And they audited specific diagnosis codes as they typically do. This was posted in LinkedIn on my dear friend, Dr. Ronald Hirsch. And he, the way he broke it down, it was like, oh my God, what is going on with these organizations, and making sure their documentation is correct. It's like low line for, it's like just it's getting to the point where it's just ridiculous. Like, what? Back to the guidance, and what are y'all following? What are y'all doing? Somebody should be taking a look at this information and verifying and validating that these diagnoses are supported before you send stuff to anybody. There's no way in the world I'd have been like, oh yeah, everything's good, send it out. And nobody looked at it. Because all it takes is a look to say, this isn't supported. This isn't, I don't understand. Go ahead. I'm sorry.
But it just, I'm just, well, yeah, I am amazed. I'm amazed at how this can, how there's no checks and balances. It's supposed to be, but there aren't. And you have people who are in these positions who are just afraid to say, this is not compliant, period. And I could only, I just know, like, even for, like, case in point, I had a case where the person was diagnosed with metabolic encephalopathy like 1 or 2 days after they were admitted. So, me, doing my due diligence and my review, I go back and I'm reading the H&P, and clearly the physician documented no confusion. So I'm like, okay. Now I'm not saying that this person does not have metabolic encephalopathy, but my question was, and I sent the query to the provider, was it present on admission? The physician responds back, yes. But how? So if you're going to do that, then you have to go back. Not only do you have to answer the query, but you have to go back and you have to amend your whoever did the H&P. Because if this goes off, I did my job and asked. So you said you responded, so it is what it is. But if once it goes out and gets audited, if you don't go back and change that, then what? Like, it's the whole the whole cycle is being missed. Like, the importance of it and the ramifications of it.
Well, in his post, he said he offered a suggestion, because he was like, this is not getting any better, even though CMS and the Office of Inspector General have been reporting findings like this for the last 10 years. His idea was every Medicare Advantage patient should be mailed a document listing their reported HCCs with instructions to take it to their next physician appointment. If the diagnosis is not supported, the patient can report it to CMS on that form, with the patient and the physician each receiving a financial reward if the diagnosis is removed and the payment to the MA plan is reduced. Other people came in. Somebody else mentioned they mentioned, this was the report. He summarized this particular plan. They looked at 211 billed diagnoses across 7 different target areas. Their findings were consistent with the past reviews. If a code for cancer or heart attack or stroke is being placed, I can't stress enough that organizations need to have appropriate checks and balances to ensure documentation supports the presence of the condition. 100% of the stroke cases reviewed were not supported. 100% of the heart attack cases reviewed were not supported. 93% of cancer cases reviewed were not supported, and 83% of embolisms were not supported. They said an excerpt from the heart attack section said, for 19 enrollee years, the medical records indicated in each case that the individual had an old myocardial infarction diagnosis, but the records did not justify an acute myocardial infarction diagnosis at the time of the physician's service. An old myocardial infarction is a distinct diagnosis that represents a myocardial infarction that occurred more than 4 weeks previously, has no current symptoms directly associated with that myocardial infection, and requires no current care. To me, this is just sloppy. It's sloppy. Somebody else says stop auto coding and reporting diagnoses that are not validated by human coders. Exactly. Somebody needs to take a look at this stuff before they send this stuff out, because it automatically goes. It's usually like a separate process, and it automatically goes. Somebody needs to take a look at that. I've been in AI, NLP, the AI and NLP space for 15 years and have US patents in the space. These tools are not ready for autonomous coding. My own tool is not ready for autonomous coding. All right. And she's in the coding field. Yeah. So until somebody changes the process or does something different, these organizations gonna get hit and hit and hit.
But I have been like those codes that you mentioned, or those conditions that you mentioned, I've been seeing those since I got into, because I started out doing risk adjustment auditing in 2014, and I've seen those. I've seen old heart attacks coded as acute, and it's like, clearly the documentation doesn't support it. But what happens is, and I've seen this for years, these because most people, soon as you have a follow-up appointment, usually within 14 days of when you're discharged back to your PCP, what happens is all they do is cut and paste. That's what they do. They just cut and paste their discharge diagnosis into their medical record. No, like it just is common sense. Like, if nobody is sitting in your office in acute congestive heart failure. Nobody.
Right.
So it's just logical. Like, nobody is sitting in your talking to you if they have a daggone infero-posterior heart attack. They're not doing it. It just defies common sense, but this is what they do. They're just so used to just clicking and copying and pasting and just letting it go. And especially when there's no immediate ramifications. It's not like, a week later somebody's saying, oh, no, you can't get paid for that. It takes years for this to get caught.
Yep. Yeah, there's this, instead of, and I understand the government, and it's like, hey, we putting this out here, we telling y'all, and of course we gonna get our cut. But we telling y'all, do something, fix this mess, fix this problem. And if you are involved, which most people jumped on that, MA plan, HCC, risk adjustment bandwagon, tighten up your stuff, tighten up your policies and processes. They thought it was a win-win, an easy way to get cost savings and say all of the things that, the buzzwords that need to be said or have been said related to that, and could potentially be the case. However, in hindsight, on audit, on review, you didn't do your part. You missed the boat. And you think your part is just making sure some diagnoses sit there. No, your part is not just to make sure that these diagnoses are documented. Your part is to make sure that these diagnoses that you have listed that this patient has been supported by previous documentation in your medical record, not just going through the list. And that used to just send me to a tizzy when I would do audits and cases and see people just taking a problem list and copying it over into their assistant. What in the whole hell is that? No.
I see that every day.
That used to, I was like, whatever that is in your system, you need to remove that. You need to have them have to automatically push these diagnoses over into an assessment and not automatically, because you probably 95% of the time, I'm going through the record and I'm like, well, you got this diagnosis. There is nothing that you documented in this particular encounter where you talked about that. So I can't cope. That's not a codable diagnosis for this encounter. Yeah, the patient may have it. I'm not saying the patient doesn't have it, but for this encounter, you didn't address it. You can't get credit for it. Period.
Right.
I'm like, and it's just easy, and that pushing that over. Oh my God, that would usually be the number one thing that I would have to come back in my reports. Stop. Just stop.
That bothers me, and what I'm dealing with now is, and what I also don't like are this software that allows providers to pick the condition and the code, because they're wrong a lot of the time. And I'm case in point, simple routine bariatric surgery. Sometimes some people have hernia repairs while they are having their bypass or gastric sleeve or whatever. So there's a lot of providers will document diaphragmatic defect. When you index defect and go to diaphragmatic, there's no default code, because it is either a hernia that's acquired, or it's a congenital diaphragmatic defect, or there's a congenital diaphragmatic defect with hernia. Those are the choices. This surgeon did just that, and right next to diaphragmatic defect, that's all it says. Diaphragmatic defect is Q79.10. First of all, the code has too many characters. The correct code in the ICD-10-CM book is Q79.1, but you have to specify congenital. When he, that's why you always got to include the other in your query. He wrote back, he didn't pick anything that I had, listed. He wrote back diaphragmatic defect Q79.10, which was in the original documentation. I sent him a secure chat, which I hardly ever do. I said, diaphragmatic defect is not, because I can't tell him that you have to make a congenital. I said, diaphragmatic defect is not a codable condition under ICD-10-CM. I'm going to have to issue you another query. I did. He responds, he just copied and pasted the exact same thing. So now you playing. Right. So now you playing. So.
Right. Like, you think I didn't see when you copied and pasted the first time, sir or ma'am or whomever? Like, really?
So this was late. This was just yesterday. So now I have to wait and talk to my manager on Monday, because see, that right there lets you know that some real education is needed. That's number one. And number two, I'm not coding the condition or the procedure because you cannot have a procedure without a diagnosis. So I'm gonna, and luckily it's a secondary procedure. It doesn't really affect the DRG because
Okay.
the principal procedure is documented and it's correct.
Right.
So, but this is just, but this is all part of compliance, because if you get audited, they're going to come back and say this is not a legitimate code.
And it should kick out from on the bill when the bill is submitted if the code is not legit also.
But this is in the op note. Like, see, that's why like you can't even put it in because it's not a code. But they don't know that when they select it.
But they're requiring them to make
Right.
these selections. They're not coders, and just because you got
Exactly.
some codes, oh my God. Yeah.
You can't tell them that. You cannot tell them that I know your job is not hard. Oh, here, I just picked the code. But is it the right code?
And do you have supported documentation for the code that you are picking? That's
Period.
even a bigger thing. Bless their
But
hearts.
I just don't understand. Like, it shouldn't be this hard, but it is, because honestly, these are like, I was talking last night and I was talking to one of my friends and I'm like, these providers are like, they're like overgrown children. Like they are petulant teenagers, a lot of them. And it's like, I'm trying to help you. Like it's
basically.
You don't know, like, look, in 3 years you'll be thanking me for this exchange if you listen.
and you take heed to the advice given.
But the issue squarely, firmly, and I put this on everything, and I always talk about it. These compliance officers have got to either put some skin in the game or just get rid of them. Because compliance should be jumping up and down. They should be the ones saying, oh, no. They should be the ones saying, you cannot copy. And why am I looking at the same note for 7 days during it? The only thing that changes is the plan. That is not acceptable. Until they get some skin in the game, it's never going to happen. These compliance has to be the easiest job in America because they don't do crap.
Don't do that. Let me tell you about this compliance officer did plenty. Let me just tell you that. Because we had multiple. So I think part of the issue is, and you may be right. Let me just, I'll give you that because I can't speak to every compliance plan program in every institution, every organization across the world. I can't speak to that. However, what I do know is if you are following the compliance guidance that has been laid out for compliance officers and compliance programs, it clearly talks about auditing and monitoring. Those are two distinct things. Your auditing usually happens kind of after the fact. What's going on? Let's check. Or you can do some real-time auditing, but then you have monitoring. And if you are seeing, to your point, if you're seeing something or somebody is bringing something to your attention, hey, we need to double check and double down and take a look at, these particular conditions or these particular procedures or what have you. You should have something set up where, you know what, I'm hearing a lot about this. When you do your annual risk assessments and you determine, what should be on your plan for the year or on your radar for the year, always have someone from your revenue cycle and HIM at that table in that discussion, because I'm sure it has been my experience. They can provide you with some doozies to let you know these are the things that we're seeing. These are the things that are being denied. These are the things, and if it's being denied now, who knows what it has been denied previously. And if it's not corrected, it's going to continue on. That is your That is your golden ticket to what it is that you should be taking a look at for that year. And while it may not, especially if you are a larger organization, it may not be isolated to just one provider or one facility. It could be something that is spread throughout. And so it's your job to take a look at that. Well, let's uncover, let's make sure, and then provide the appropriate education, corrective action plan to get folks on board if you do find that there is an issue, and then come back, correct it, provide education, give them a little time to make the appropriate corrections, and then come back and validate and make sure that things are the way they should be. That's what you're supposed to do in your compliance office. That's part of what you do. I know there's a lot of things with new technology and new programs and new practices, and y'all want to look at this and then that's all great, fine, well and good. But the rodeo is here. The regulatory rodeo is here, and compliance officers need to be at the helm of this, in front of this. You need to be proactive, not reactive. And again, it just takes a conversation. Hey, what have you, or we had committees. We actually had a compliance committee that was made up when we met every month. That was made up of various high profile priority areas, that risk areas, high risk areas, that's the word I'm looking for, that could potentially run amok. And so we wanted to touch base. Hey, what y'all seeing? What's going on? Something that we need to know. And I mean, it was set in a way that folks felt safe. This is a safe space for us to talk about and uncover and look at and correct and slide checks if we need to, versus having them knock on the door or whatever. But let us get a grasp and understanding of what's happening within our organization. That's the job of compliance. I'll get off my soapbox now. And so if you're doing that, you working your ass off.
Right. Oh, I agree. But I'm telling you, like, I have very few places, actually none, where I've worked, and I'm being honest, has there been an effective compliance component. And that's because compliance is actually supposed to support coding. They're supposed to support CDI. Well, this is why you have, matter of fact, like I had to send this provider like 3 queries. One of them was the metabolic encephalopathy, but it's like, but until there's an incentive to do better, because in the perfect world, there would be no queries because the documentation would be supportive of what is actually going on. And they will clarify, they will rule out conditions. That's in the perfect world. We know that it's not going to happen. But you should not be seeing the same queries constantly, because then that clearly lets you know that there needs to be some education. Like, the facility I cover, I mean, if you come in there with a bruised toe and a cough, you have rule out sepsis. Come on. And then it's okay, because I'm not knocking nobody's hustle. Okay, you're infectious disease, you trying to, do your thing, fine. But the attending physician should, in the discharge summary or somewhere in the notes, say, this has been ruled out.
Yep.
That's not hard.
Nope.
But they don't do it. And then you have to validate after the discharge summary comes. Then you got to send the clinical validation query after the person is discharged, because the discharge summary doesn't even have it at all. So what did you do? Does this person have sepsis or not?
Right.
Or whatever the condition is. Like, they can't even give you the principal problem why somebody came in. Right. Which, that's your job.
Exactly. And this, my dear friends, are why coders may never go away. They may, the rules or the roles may shift and pivot, but the profession, I don't see it. I don't see it at all.
No, me either.
I don't. AI or not. Let AI be your friend, and AI help you comb through all of the information and help you find things that may be running amok and going in an error. But nope. So that is a high note.
Yeah. Job security is always good.
Oh, high note. No. All right. Well, thank you all again for joining the Saturday morning tea or checking out the replay. And let me ask, was the tea spilled today? Was the tea spilled today?
Yeah, absolutely.
Yes. And Renita says, use it as a tool to assist a human touch. I like that quote. Yes.
That is. Yeah, I like that.
I like that. If this information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. As you leave, don't forget to hit the like button or thumbs up, and also check out the Coding Nurse channel on YouTube. There are gems over there. Check him out. Again, this has been a great session. Mr. Jesse, do you have any closing parting words today?
No, it's just I enjoy our relevant discussions all the time, and we really talk about what is really going on out here in these HIM streets, because people need to hear the truth.
That's true.
And there are a lot of people who listen to our replays and watch our replays who are considering coming into HIM or coming into the industry. It is a wonderful industry with a lot of opportunities. But when you come with a certain knowledge, when you get into it with certain knowledge and certain foundational truths, you'll be able to flourish, and you'll be able to see all of the tomfoolery we talk about every Saturday.
And be marketable while you're at it. Right. She said, I love it here. I found my tribe. Yay. All right, y'all. So thank you all again for joining. And remember, be safe, be kind, and don't wish for it. Work for it. Until next time, take care, and we will talk to you next week. Bye-bye.
Bye.